So hello friends, so I'll be talking on this drug Levosimendan in critically ill and the evidence so far for the use of Levosimendan. So the topics I would cover is pharmacology, mechanism of action, adverse effects, dose and precautions, and what are its effects on cardiac variables. And there are a lot of studies, at least I would say there are more than 15 studies, and some of them are all landmark studies done to compare the effectiveness of levosimendan compared to the dobutamine or to the standard group. So these are some of the landmark trials: Lido trial, Ruslan trial, Survive, Revive, Lionheart, and Leica. So Lionheart and Leica are the more recent studies which have sort of re-emphasized its role in refractory heart failure conditions and a few other conditions, and whether it has a good role in cor pulmonale. So this is something useful for ICU because we do see quite a few of cor pulmonale patients or RV failure, and in calcium channel blocker, and does it have a role in septic myocardial dysfunction. Conclusions and take home message. So if you look at the inotropic agents that we have to use to enhance the contractility in heart failure, so these are the different group of drugs. So as you see, levosimendan comes in this calcium sensitizing agents along with another drug called pimobendan. So what we tend to use in ICU for cardiac contractility or dobutamine as a primary agent, and in chronic conditions with AF we tend to use digoxin, milrinone in some cases. So levosimendan also is a newer drug, and the evidence has recently been very compelling for its benefit in heart failures, especially refractory heart failure and right heart failure. So the mechanism of action, as you see, the levosimendan binds to cardiac troponin C, and by binding to the cardiac troponin C, it increases the sensitivity of calcium, and thereby it increases the force of contraction. Along with that, it opens up the potassium channels in the vascular smooth muscles. So by opening up potassium channels, it helps in the vasodilation. So it has a increased contractility of the heart, and along with it there is a dilation, vasodilation that happens, and which is useful for any heart failure because we need good contractility and we need a good afterload reduction. So the dosage that is being used is in the range of, so there is a bolus dose followed by an infusion of levosimendan. So the bolus can range from 12 to 24 micrograms per kg as bolus for 10 minutes, and the infusion always lies in this range, zero point 0.1 to zero point 0.2 micrograms per kg per minute. So this is the typical infusion that has been recommended and has been studied in all the studies that I would be referring to. So the adverse effects, it can cause dizziness. The main adverse effect which we should be worried is hypotension, because any of the heart failure, what we would be worried is the hypotension, because they would already be hemodynamically be compromised. So we need to bear this in mind when we are using levosimendan. Vomiting, headache and dizziness are some of the other side effects. It can cause hypokalemia because you saw it uses potassium to open up potassium channels, and causes vasodilation. So hypokalemia is something, and like in dobutamine, which causes tachyarrhythmias, even levosimendan can cause AF, ventricular tachycardia, or extrasystolia. So these are some of the arrhythmogenic effects which are unique to any drug which induces contractility, I suppose. So contraindications for levosimendan is any patient where there is a LVOT obstruction like aortic stenosis or left ventricular outflow tract obstruction. Levosimendan cannot be used, or if there is a refractory hypotension. So one has to be very cautious and judicious in initiating levosimendan because it can cause hypotension, and whether if there is hypersensitivity to levosimendan, or if there is a creatinine clearance less than 30 ml per minute, that also becomes a relative contraindication. So when we are using levosimendan, as you know, the potassium tends to come down. It is advisable to monitor potassium, and obviously we use levosimendan in ICU setting, so there should be continuous sort of ECG monitoring. So the short-term benefits. So there are there are many studies. So this is one study which was done in 146 patients with NYHA symptoms of class 3 to class 4 with a poor LV function. So with LV ejection fraction of 21 plus or minus 1, and where, see, any heart failure, there are 2-3 things which make which get them to decompensate and manifest. One is obviously you will have a low systolic function, and there is a high filling pressure. So you have a pulmonary wedge pressures which are high, and then you have a low cardiac output. So this is a typical conundrum which tends to decompensate any heart failure. So this study looked into this, where LV function was low, wedge pressures were high, and you had a low cardiac index. And what they found is levosimendan improves the cardiac index by increasing the cardiac contractility. And the key advantage is it reduces the filling pressure or reduces the wedge pressure. And you will see in all the subsequent studies that I would be citing, they have looked at these markers, whether there has been decrease in the pulmonary artery pressure, whether there has been decrease in the pulmonary capillary wedge pressure, or whether there has been decrease in the pulmonary vascular resistance, which are the key determining elements of circumventing or addressing the heart failure patients. So the study, they did a 2:1 randomization. So the levosimendan was titrated for 4 hours. So in this study, they gave at a dose of zero point 0.1 micrograms per kg per hour, and was titrated by increasing it to zero point 0.4 micrograms per kg per hour. So they had 146 patients, levosimendan, and they compared placebo. As you see, they looked at all these indices. Stroke volume increased in levosimendan by 28% compared to placebo. Cardiac index improved by 39%. Heart rate increased by 8%. So this is very important for our ICU setting when we are dealing with heart failure. And these are the indices we want to see improvement. So your wedge pressure, the filling pressure, or whatever we measure in the echocardiogram as a filling pressure, pulmonary capillary wedge pressure came down, and your CVP came down, which is again a reflection of reducing the preload, and pulmonary artery pressure also came down, which is also very good. MAP came down, and symptomatically dyspnea and fatigue component also was less, and serious adverse events, when they compared with placebo, there was no significant serious adverse events that was alarming in levosimendan. So this was the findings in this study. And this is a graphical representation. As you see, the change in stroke volume as compared to placebo was much better in levosimendan, and heart rate also was it was much more than placebo, and the cardiac index, as you see, was much better than the placebo. So this was another study from Finland. So here they looked at whether the levosimendan, see, like we know dobutamine, when we use, the effect of dobutamine is there only when the infusion is going on. But with regards to levosimendan, there is a prolonged effect of this drug even after stopping the drug. So what they found is, even after discontinuation of the drug for 24 hours, the effect lasted up to 48 hours. There was no attenuation of the drug, or there was no wearing off of the effect until 48 hours. The reason is, this particular study has looked into the metabolite of levosimendan, and the metabolite is OR1896, and this is referenced in multiple literature. And they found these metabolite levels were similar even after 48 hours. So, which means to say, this levosimendan has a much prolonged duration of action. Sometimes you can look at it as having prolonged benefit, or if side effects are very severe like hypotension, even that can last longer, because this metabolite remains in the, that's why it is contraindicated where creatinine clearance is less than 30, because this drug can have a very prolonged duration of action. And it has a dose dependent effect. Again, the dosage, as I said, is 0.1 or 0.05 to zero point 0.6 micrograms per kg per minute is what they used. And more than 0.2 micrograms per kg per minute, some of the side effects which I mentioned, headache, vomiting, and hypotension, persisted. So this was a landmark trial called Lido trial that came in Lancet. So this was a multicentric randomized controlled trial where they used levosimendan 24 micrograms per kg as a bolus. So generally it's given as a bolus followed by an infusion of 0.1 to 0.2 micrograms. Here they used 0.1 micrograms per kg per minute for 24 hours. And this was compared with dobutamine. As you see, the previous study they compared with placebo. So this they compared with dobutamine to see if this drug is superior to dobutamine. Okay. So the dose was doubled if there was an inappropriate response to levosimendan. Within 2 hours, if they did not find response, they doubled the dose to 0.2 micrograms per kg per minute. So primary endpoint in this particular Lido trial was to see whether there was an improvement in the cardiac output by 30%, or if there was a reduction in the pulmonary capillary wedge pressure or filling pressure by 25% in 24 hours. So these were the primary endpoints they looked in. So this was the results. 203 patients were included, 103 in levosimendan and 100 in dobutamine. As you see, the improvement in the cardiac output and reduction in the wedge pressure, the primary endpoints were attained in a much larger group of patients, 28% compared to 15%. That was statistically significant. And even here, there was a mortality benefit. Mortality at 180 days was less in levosimendan group as compared to the dobutamine group. So, which goes on to show the effect of levosimendan was much more enhanced and profound when compared to dobutamine. So, the conclusion from the Lido trial is a landmark trial. So, in cardiac output heart failure, levosimendan improves hemodynamic performance more effectively than dobutamine with reduced mortality up to 180 days. So this was the graphical representation. The triangle one is the levosimendan. So you see there is improvement in the cardiac output, and you see the pulmonary capillary wedge pressure which is down in the levosimendan group, and survival also is better in the levosimendan group. So this is also a landmark trial, survive trial. So that came in JAMA 2007. As you see, this was a multicentric trial done in 75 ICUs in 9 countries between March 2003 to December 2004, and it was a much larger trial. They looked at 1,327 patients, 664 in the levosimendan group, 663 in the placebo. They looked at 180-day mortality. There was no difference between levosimendan and placebo. They looked at the BNP levels reduction, which is a good sign that the BNP level reduction was much greater in the levosimendan group. They looked at the other endpoints like 31-day mortality, hospital survival, and dyspnea at the end of 24 hours or heart failure related mortality. Surprisingly, in survive trial, there was no difference between the levosimendan and the placebo group, and this tempered the enthusiasm on the role of levosimendan after this survive trial came. And the side effects of headache and potassium problems or hyperkalemia was much higher in the levosimendan group. So this came in 2007, after which again there were questions raised whether levosimendan is going to be really beneficial because of this negative trial. So the conclusions authors made was levosimendan, although it reduced the biochemical marker of heart failure, which is good, but it did not have any bearing on reducing 180-day mortality, and there was no effect on secondary outcome. Then came this Ruslan trial. So this also is a landmark trial. So here the aim was to look at efficacy of levosimendan in LVF, left ventricular failure, complicating acute MI. So primary endpoint was to see whether levosimendan induces ischemia. Like you would have seen cardiologists telling dobutamine can induce ischemia. So they wanted to see whether levosimendan induces myocardial ischemia and whether it causes hypotension. And secondary endpoint was to look at risk of death, whether it had any beneficial effect on reducing the risk of death or worsening of heart failure and all-cause mortality. So this was 504 patients randomized between levosimendan and placebo. The dosage they used was 0.1 to 0.4 micrograms per kg per hour. So they saw the inducible ischemia and hypotension was similar between levosimendan and placebo. But what you see here, interestingly, is the risk of death with worsening of heart failure at the end of 6 hours was significantly less in levosimendan as compared to placebo. That was statistically significant. And at the end of 24 hours also, the risk of death was significantly less. So in the levosimendan group, 40-day mortality also was significantly less, and 180-day mortality also was very low. So again, this is in contrast to your survive trial where it did not show benefit. The Ruslan trial shows there was a mortality benefit at 6 hours, at 24 hours, 14 day and 180 days. There was a mortality benefit with levosimendan. So the conclusions the authors made was levosimendan at 0.1 to 0.2 micrograms did not induce myocardial ischemia or hypotension, and it did reduce the risk of death and reduce the worsening heart failure. So this was in LV failure. This was in patients with left ventricular. Then came this revive trial in 2010. So this was a US trial, 1,327 patients randomized between levosimendan and placebo. They looked at 90-day mortality. There was no difference in this revive trial. So at that point of time, when the heart failure guidelines came, the European heart failure, they again underemphasized the role of levosimendan based on this revive trial. The survive trial was negative, revive trial is negative, Ruslan trial is positive. So they said levosimendan safety and efficacy is uncertain. It may have some role in reversal of beta blockers. So in the guidelines, so there was no emphasis on its benefit based on this particular revive trial. So in the Revive trial, there was a Revive 2 trial where they looked at primary endpoint was to look in the change in the clinical improvement at 5 days. In Revive 2, they used Levosimendan 6 to 12 micrograms per kg as bolus, followed by the same one, zero point 0.1 to zero point 0.2 micrograms per kg for 24 hours. So they had 600 patients in Revive 2. The Revive 1 is that what I showed, 1200, which did not show benefit, and 299 in the Levosimendan group and 302 in the standard group. So the primary endpoint was to look at improvement in the clinical symptoms by 33%. So they did see there was an improvement in the clinical symptoms by 33% in the Levosimendan group as compared to the standard. So that was the primary endpoint that they were looking into. And the need for rescue treatment was less in Levosimendan group, 15% compared to 26%. And worsening of tachypnea also was less in Levosimendan, 7% versus 12%. And someone who was unresponsive to treatment also was less, because unresponsive was 10% in standard, 6% in Levosimendan group. And hospital length of stay also was less. So these were some of the positive findings in the Revive 2 trial. And adverse events, it did have hypotension and atrial fibrillation tended to be more common in the Revive 2 trial. So then after this, this was the most recent trial which came to look at whether the role of levosimendan in patients undergoing VA ECMO, because ECMO patients are the ones who would have heart failure, and ECMO is used as a mechanical support, to see if levosimendan helped them to be weaned off the ECMO. So this was a French trial. It was a retrospective single center study. It was a propensity matched sort of so they took a patients who were propensity matched and then they analyzed the data. So levosimendan here was used at 0.2 micrograms per kg per minute for 24 hours. It was used for 3.2 plus or minus 2.8 days after VA ECMO to get them to wean off. So they had 150 patients, and as you see, the left ventricular ejection fraction or systolic function improved from 21.5% to 30.7% in levosimendan as compared to standard. That was statistically significant. And as you see, the more number of patients were weaned off ECMO in levosimendan group as compared to standard, and that was also statistically significant. And even 32 survival was significantly better in levosimendan group as compared to standard. So this is as recent as 2019. Again re-emphasizes that levosimendan may have a beneficial role in improving the LV function and helping them to wean off from the mechanical support. But when they did the propensity score matching analysis of 30-day survival, this speed tended to be not significant. But as you see, the signals are towards favorable benefit. So these are all about heart failure, say LV failure, where they were sort of a milder variants of heart failure. So now we look into the studies with advanced heart failure, because this is what is important for intensive care setting. So this was a one trial which came from Austria called Livor Rep Study. Okay, so this came in 2014, which is a multicentric, prospective, randomized controlled, double-blind, placebo-controlled parallel group trial. So they defined advanced heart failure as LV ejection fraction less than 35% with NYHA class 3 to class 4 symptoms. Here again they used levosimendan 0.2 micrograms per kg per minute for 6 hours. If you see chronic heart failure, they use this treatment as a chronic therapy. They use for 6 hours every 2 weeks for 3 sessions, which means over 6 weeks they gave this infusion for 6 hours based, like they run heart failure clinics where they get the patients, give them a 6 hours infusion every 2 weeks for 3 sessions, and they try to see if it have any favorable benefits. So the primary outcome they looked was to look at proportion of patients who had more than 20% of clinical improvement, which they quantified with 6-minute walk test, and to see very objectively if there was any objective clinical improvement in these patients. And they looked at more than 15% score increase in the Kansas City cardiomyopathy score. So they had this, they followed a questionnaire to ascertain improvement in the symptoms, and they used a score called Kansas City cardiomyopathy score. So the primary endpoint, which proportion of patients more than 20% clinical improvement, as you see, was 19% in levosimendan as compared to standard 15, but that was not statistically significant in the Livor Rep study. So the conclusions they made in this particular study was pulsed infusion of levosimendan did not improve functional capacity or quality of life in patients with advanced heart failure. Then this Lionheart trial. So I want the listeners to little focus on Leica trial and Lionheart because these are the most recent trials, and this was a Spanish trial that came in 2018 in European Heart Journal. So Lionheart trial is a multicentric, prospective, randomized controlled, double-blind, placebo-controlled parallel group trial, 2:1 randomization. Again here they used same dose, 0.2 micrograms per kg per minute for 6 hours every 2 weeks into 3 sessions, which is over course of 6 weeks. And primary endpoint, they looked at change in the pro-BNP. If there was a reduction in pro-BNP, then it had a beneficial effects. So they had 69 patients, 48 in the levosimendan, 21 in the placebo. As you see, the area under curve for pro-BNP levels was significantly less with levosimendan group as compared to the placebo. And heart failure patients requiring hospitalization also was significantly less, hazard ratio of 0.25, which means the patients needing admission into hospitalization was much less in levosimendan. And they looked at heart failure related quality of life. There was reduced decline in levosimendan group. That was also statistically significant. And hypertension was more, but that was not statistically significant. So the Lionheart study basically said it does improve biochemical markers, and heart failure associated admission into the hospital was less, and the quality of life was better in the levosimendan group. So then this Leica trial came. So this was also the recent trial from the Spanish group. This was also multicentric, prospective, randomized, controlled, double-blind, placebo-controlled parallel group study. So the primary endpoint they looked is admission into hospital for heart failure symptoms. And the secondary endpoint was to look at the cumulative incidence of hospital admission for heart failure in the Leica trial. And they looked at hospital mortality at 30 days, 3 months, 6 months, and 12 months. So they looked at all this mortality. And 97 patients, 17 levosimendan and placebo 27. The primary endpoint, which was the hospitalization, there was no difference. But mortality, as you see, was significantly less in the levosimendan group as compared to the placebo, and that was also statistically significant. So as you see in advanced heart failure, if you have to subscribe to Leica trial and the Lionheart trial, so it did show strong signals towards benefit to some extent, especially the Leica trial. Okay. So then we'll move into the whether levosimendan has any effect on renal perfusion, which is very important in our ICU. See, the main tenets for any heart failure where there is cardiogenic shock is to improve the cardiac output and to reduce the preload, reduce the CVP, and improve the renal perfusion pressure. So these are the tenets of managing any heart failure in improving the perfusion. So whether this achieves. So the Lido trial, which was a old trial, when they did look into the subgroup analysis, they saw the serum creatinine level came down significantly in the levosimendan group and compared to the dobutamine group, and that was statistically significant. And the similar trends was seen in a trial by Ilmaz et al., which was a Turkish study. So basically, in the group which got levosimendan, the reduction in creatinine was better in these studies, and there are a couple of other studies. So this was another study which came from Sweden by Lanimer et al., which was again a single center randomized double-blind study where they compared levosimendan versus dobutamine at 12 micrograms per kg plus 0.1 micrograms per kg per minute. This was compared with dobutamine at 7.5 micrograms per kg per minute. 1:1 randomization for 75 minutes. So they had 33 patients with LV ejection fraction less than 40, where GFR was less than 80 ml per minute. And they saw the glomerular filtration rate GFR increased by 22% in levosimendan group, and in dobutamine it remained unchanged, which means it has a favorable benefit on reducing the creatinine, improving the GFR in these studies that it was shown and compared to dobutamine. So this was another Turkish study where Zemljik, where 3 months post infusion, they found the reduction in serum creatinine was better in levosimendan as compared to the control group. That was statistically significant, and even there was increase in the creatinine clearance, 53.6 versus 44 in the control group. So that was about renal. So what we saw until now is it had a favorable effect. At least the recent trials tend to indicate that it has a better benefit in heart failure compared to dobutamine. and even renal indices showed favorable benefit with Levosimendan as compared to dobutamine based on the previous Swedish trial I showed and by the Turkish trial that I showed. So what about carpal nail? I think this is also a very challenging condition we deal in ICU time and again. So there are good number of studies to show beneficial effect of Levosimendan here. So in the carpal nail, the key tenets of management is to reduce the pulmonary vascular resistance and to reduce the pulmonary capillary wedge pressure. So Levosimendan has shown to cause your pulmonary artery dilatation and improve the right heart myocardial contractility and reduces the right heart output, which are all very important in dealing with carpal. The pulmonary artery hypertension is defined as where your pulmonary artery pressure is more than or equal to 25. And for all the listeners, you need to know the grades of pulmonary hypertension and when Levosimendan is found to be beneficial and what indices it's beneficial. So grade 1 is where you have PAP more than 25 and it may be a mild variant. So grade 5 is more severe where there are multiple factors. There may be cardiac factors, there may be lung factors, or there may be systemic factors contributing to high PA pressure. But grade 2 is where pulmonary artery pressure is high due to LV failure, where there is a left ventricular dysfunction leading to increase in the PA pressure is called as grade 2. Grade 3 is where PA pressures are high due to the lung conditions. And grade 4 is where PA pressures are high due to chronic pulmonary thromboembolism. So this is the grading of pulmonary artery hypertension, and we'll see whether Levosimendan has had favorable benefit. So one of the earlier studies came from Jiang et al. From China, where they looked at patients with grade 4 pulmonary hypertension, which is due to chronic PTE, 45 patients, and they found with the use of Levosimendan, the patient's grade improved from grade 4 to grade 3 in 7 out of 13 patients. And they looked at Borg dyspnea score that got better, 6-minute walk test got better, and biochemical indices improved with the use of Levosimendan. And this was a study from Russia where Martinuik et al. They used Levosimendan infusion for 24 hours in 9 patients with class 3 and class 4 pulmonary artery hypertension. And they found these are the indices that were lowered with the use of Levosimendan. Pulmonary artery systolic pressure came down, which is good. Mean pulmonary artery pressure came down, which is good. Mean RAP, which is preload, was reduced. Pulmonary vascular resistance was reduced. And there was reduction in the biochemical parameters NT-proBNP. And this was a study from Austria, Police et al. 18 patients, they looked at possibly grade 2, where you have a pulmonary artery hypertension due to LV failure, where LV ejection fraction was less than 30 and cardiac index was less than 2.5. So, and patients had RAP more than 10 and wedge pressure more than 50. So, Levosimendan infusion was used for 24 hours and they saw reduction in wedge pressure, mean pulmonary artery pressure, systemic vascular resistance and pulmonary vascular resistance. So this was another study by Ilmas et al. 40 patients with RV dysfunction, and they found there was improvement in the RV ejection fraction, which is very important, and reduction in the pulmonary artery pressure with the use of Levosimendan. So this was an Indian study by PJ Chandigarh, where they used Levosimendan and showed improvement in the biventricular dysfunction, and they demonstrated reduction in the mean pulmonary artery pressure, SVRI and pulmonary vascular resistance. So you have around 6 to 7 studies to show Levosimendan had a favorable effect in the RV failure or pulmonary or pulmonary artery hypertension of varying degrees, grade 1 to grade 4. So in all the categories, it did show favorable improvement in all the pulmonary indices, so which is of vital importance for us. So how about just last couple of slides, calcium channel blockers. So because calcium channel, we know that because of calcium channel blocker, you do not have calcium for cardiac contractility, and you know Levosimendan acts by increasing the sensitivity of calcium and improving the myocardial contractility by binding to cardiac troponin. So the main management principles of calcium channel blockers is we give calcium, we give insulin plus glucagon and catecholamine. So these are the only tools that we have. So Levosimendan has shown by increasing the calcium sensitivity, it enhances your cardiac contractility and may act as an adjunct for these other treatments. And that was the study which has looked at it. So this is also of interest in for ICU, where they used Levosimendan in septic myocardial depression. So this was an Italian study done in 28 patients where they compared levosimendan versus dobutamine, and they have done monitoring of laser Doppler flowmetry. They have looked at all these indices of organ perfusion like lactate and gastric tonometry and creatinine clearance at baseline and at 24 hours. And they found that in patients with septic myocardial depression, levosimendan when compared to dobutamine had a better ability to reduce the wedge pressure, improve the cardiac index, reduce the left ventricular end diastolic volume, improve the LV ejection fraction, improve the urine output, and reduction in lactate was better than in dobutamine group. So again, in septic myocardial depression, this Italian study showed more benefit with the levosimendan as compared to dobutamine. So, to conclude, so levosimendan, as you see from multiple studies, it has a potential advantage in refractory heart failure or decompensated heart failure, where a lot of other medical therapies have failed. So, this has shown increased benefit in improving certain key variables which are specific to the cardiac function. And especially this Lionheart and Leica trial has demonstrated that intermittent infusion, especially in advanced heart failure patients, have several clinical benefits. And these benefits are multifactorial. So it did show improved biochemical variables, biomarkers, and it did improve your readmission to the hospital. It did improve quality of life, it did improve symptoms, and it did improve heart failure related mortality. So it had a multimodal effect in showing improvement in various dimensions of healthcare indices. And the three key mechanisms of action levosimendan works is with positive inotropy by increasing the myocardial contractility, and it has a cardiac protective effect by improving the ejection fraction and reducing the filling pressure, reducing the pulmonary artery pressure, and reducing the mean pulmonary artery pressure and pulmonary capillary wedge pressure, and causing vasodilation, which reduces the afterload significantly. And another important aspect is its duration of action is quite prolonged because of this metabolite OR 1896. We tend to remain in the body for quite some time. So these are some of the distinct advantages. So thank you very much. So in essence, so levosimendan, from all the studies, what we can make out is it did score better than dobutamine in many of the indices. So the advantage in ICU would be in some of these heart failures, and more so in the right heart failure where we have a terrible difficulty in attaining good control over hemodynamics. It may prove to be valuable in certain refractory situations. And of course, in calcium channel blocker, this agent could be considered as an adjunct. So thank you very much. So if you wish to rehear, you can visit my website www.drpradeeprangappa.com and rehear. Thank you all.